Well, first of all, we should all be cooperating, collaborating for the healing of the patient. Okay. And so if Dr. So-and-so at a major cancer center down the street has all the answers, okay, great. I'll listen to it. But if the extreme natural person, which I would consider I'm a pretty extreme natural person, but at the same time, if a patient comes in here and we're facing very serious, dire consequences of not doing something, then, we all have to work together for the healing of the patient, period. And if it takes all three of us to get the patient healed, that's what we should do.
Hey, this is Ari. Welcome to the Energy Blueprint podcast. With me in this episode is Dr. Leigh Erin Connealy, who is a prominent leader in the integrative and functional medicine field. She is the medical director of two clinics, the Cancer Center for Healing and the Center for New Medicine. The combined 30,000 square foot clinics have become the largest integrative medical clinic in North America and have been visited by patients from all over the world, with 47,000 patients and growing. Dr. Connealy created the Cancer Center for Healing as a result of the epidemic spreading of cancer. Patients receive scientifically based treatments and integrative protocols, and she's created acute awareness for the need to focus on cancer prevention, providing unique testing to determine the early stages of cancer years before a scan actually reveals the presence of cancer. Through sophisticated testing, she and her skilled team create personalized treatment plans for early to late stage cancer patients. In this episode, we do a deep dive on all things cancer, its causes, misconceptions, how it's viewed in the conventional medical community, in the alternative and holistic communities, widespread myths and misconceptions about cancer, treatments for cancer, and lots of other things that come to mind, cancer screening, and some kind of surprising findings around the usefulness and potential risks of that, and lots of other stuff related to cancer. This is going to be part one because there's a whole bunch of questions that we didn't get to, but there's lots of wonderful information in this episode. And one other thing is, after you listen to this, reach out to me or comment on the YouTube video for this episode. You can email me at ari@theenergyblueprint.com and let me know if there are any questions you have related to cancer that we didn't get to in this episode, so that I can ask her that in part two. So with all of that said, enjoy this episode with cancer specialist, Dr. Leigh Erin Connealy. Welcome to the show, Dr. Connealy.
Great to be with you, Ari.
So I want to get started with probably a question that you could talk for maybe 2 hours about, but maybe you can give me a sort of succinct answer, just as sort of a lead into this whole discussion. So I want to talk to you about cancer, and I'm curious what you would say to the question of, what do you think are some of the biggest misconceptions that people have on this topic? In the general public, what do people get wrong in their assumptions about the nature of cancer?
Well, I think the biggest thing is people think cancer is genetic. That's number one. And they think, so if their mom or dad had it, that's why we do family histories on physical histories and physicals. And we always ask family history, right? And so, but genetics plays a very small part in whether you're going to get cancer or not. Number two, people think that it's like something foreign and strange and ominous when they get diagnosed. They never thought that, that could be possible. And that cancer just appears one day. And it actually is probably an 8 to 10 year process. And so then when they get diagnosed, I think when people get diagnosed, people are not afraid of other diseases like they are cancer. And so, when they get cancer, they're immediately scared, as opposed to like, let me research and find out every single thing I need to know. They tend to go to the doctor and the doctor says, oh, this is what you have. this is what we mechanically do, and then this is how I will follow you. And people don't ask the why, where, when, and how did this occur.
Anything else that comes to mind on the as far as myths and misconceptions?
Well, one thing, they think it's an older person's disease,
Uh-huh.
and it used to be an older person's disease, and now it's more can be a young person's disease, and not something just somebody 60 years and older.
Okay, let's dig into each of those 3 points. So, number one, you said it's not genetic. So, if it's not genetic, it does involve genes. It involves DNA in some way, right? That's part of the mechanism of cancer. So, explain what you mean by it's not genetic.
Well, your genetics, whether it's a family history of diabetes, heart disease, or cancer, you have something called epigenetics. And epigenetic means above. And so there are many, many factors influencing your genetics every single second of every day. And so there's something called the exposome. The exposome is what every person's influenced with in their entire existence. So that is what is really going to trigger the genetics, whether, whatever you're eating, your exercise, your exposure, every single thing that you're exposed to in a day.
Mhm. I think this is a really important point because cancer is often conceptualized as this internal problem. There's something wrong inside of me. There's this genetic thing. This people think that they're going to have some mechanisms that mutate their DNA that drive cancer development for sort of arbitrary reasons, bad luck, bad genes, and then you just have this uncontrollable cancer growth that's growing. And I think that this connection between the exposome, lifestyle and environmental factors, and how that interacts epigenetically to alter gene expression or to affect, the likelihood of DNA damage is very poorly understood. It's sort of, and part of this is related to the timeline of it. As you said, it takes 8 to 10 years. We have a difficult time, I think the human brain has a really hard time perceiving cause, the nature of causation when it happens over a long period of time. We're really good about understanding cause and effect when it's sort of relatively instant. It's happening within seconds or minutes or maybe days. But when it's extended over months or years, we have a very difficult time understanding causation and linking whatever this internal mechanism of cancer development is back to the exposome is hard for our brains to do. How would you help people understand that connection better?
Well, I think, first of all, I think everybody needs to look at their 24-hour day. Okay. And that's not something that we're really taught, like, oh, how do we sleep? Okay. What is the quality of our sleep? 50% of the population really doesn't sleep that well, maybe even more. And then they think, oh, well, that's just normal. I don't sleep because my friend doesn't sleep or someone else, right? And they talk about it. And just that alone. And then water. Okay. Today, most of the water is not sufficient to, drink because it's, pharma water and or polluted water. So now we have to drink purified water, right? Most people drink out of plastic water bottles and they think that's okay. Then people really aren't mindful of what they're putting into their body. And so, people, there's for hundreds of years, especially the last 100 years, you think about, it needs to be low sugar and then it's, high fat. And then it's all these different, philosophies on, what we should be eating. And we really need to eat like our ancestors did. And so people are really not mindful of their eating and what they're putting in their mouth. And then we have 800 muscles, and exercise has a profound effect on oxygenation, lymphatic drainage, how their brain works. I mean, so many different things, right? So And then, if you think about everything that you're exposed to in a day, and then you think about your daily stress. Okay, now stress is part of life, but abnormal amounts of stress. And then how do we recalibrate when we have abnormal amounts of stress? Instead, we just kind of like, okay, we have to muscle through it. But I think some consciousness and mindfulness in how do we live our 24-hour day?
Mm-hmm.
Because we know that, in a study of 44,000 identical twins, that whether they were going to get cancer was determined with their eating and their lifestyle.
I think this point is so important, and yet, I think what I was saying earlier, that the time scale of it makes it hard to see causation, but I think there's another aspect to it, which is that we've all been sort of indoctrinated into an understanding of health and disease where we ask questions like, what is the cause of this particular disease? And we look for a singular cause of it, and that singular cause is often mistakenly conflated with whatever the internal, biochemical mechanisms are that are linked with the development of that disease. We mistake the internal mechanisms with quote unquote the cause. Like the idea that a neurochemical imbalance in the brain, a serotonin deficiency, underlies depression, or that the cause of heart disease, quote unquote, is your high cholesterol levels. And then we look for the solution by attacking this singular mechanism, which we've identified as the cause. We take a drug to alter the levels of serotonin in our brain, or we take a drug to lower the LDL cholesterol, and so on. This is kind of how we've all been trained to think about the nature of disease development and how we're supposed to try to treat or to try to cure or reverse the disease. And the picture of the exposome and how that relates to this isn't like that. We're talking about dozens of factors, each of which triggers dozens or hundreds of different mechanisms that are affecting the overall, systemic function, metabolic function, cellular bioenergetic function, all of which basically creates a sort of environment that is either pro-cancer development or pro-other disease development, or anti-cancer development. And that landscape of all of that complexity and nuance, even though it's vastly more accurate in understanding what's going on to drive a disease like cancer, is much harder for our brains to wrap around than the idea that it's just DNA mutations, and the way we do it is the way we affect that mechanism of that disease is by taking this drug that blocks XYZ mechanism. You know what I mean?
Exactly. It's a reductionistic approach.
Mm-hmm.
And yeah, everybody is looking for that one thing. And life isn't that simple. I tell people, you live in a miracle. And the miracle is 50 trillion cells in this incredible, complete world of 8 billion people. And so, but like you said, we've been taught and indoctrinated to be, okay, here is a disease and here is a drug, or here is a surgery, or both.
Mm-hmm.
And you may need medications. There are times that a patient may need medications. And in an emergency, it's very, very helpful. But for the chronic management of anything, a doctor's goal should be to de-diagnose a patient.
Mm-hmm.
But they get paid based upon how many diagnoses they have.
Yeah.
And so, and you gave the example of the cholesterol. I mean, that has not done anything to extend the disease. I mean, heart disease is still as prevalent as the number one cause of death, despite the use of lowering our cholesterol levels. Not to mention all the ramifications that are involved with taking a statin and how critical and crucial role cholesterol plays in your cellular health.
Mm-hmm. One of the other things you mentioned earlier was that cancer used to be an older person's disease, and now more younger people are getting it than ever before. Why is that?
Well, I think it's many different factors. Okay. I think if you look at one, the lifestyle and what the average person probably feeds their children. Okay. And I mean, I grew up in a time where we ate off, we had a farm, we ate, real food, and we ate like an ancestral eating program. Okay. But today it's fast food, it's cereal. What can we do that's very quick and easy? So, food, they're not outside. Kids aren't getting sunlight and being outside on, hours and hours a day. That's like critical for their growth and development. I think probably more exposure to toxicity. I don't think we're using less toxins. I definitely think we're having more toxins. I think that people bring their kids to the doctor and they are given a medication. So, one of the most prescribed things is antibiotics. And so that alters, the microbiome. And I think just the food we're eating, if you think about how our microbiome is being changed, which is 80%, houses 80% of our immune system. And I think also electrical output now from everywhere and anywhere. I think that can change the whole electrical part of a cell. And so I think there's a different kind of stress today compared to when I was young. I think it's a whole different level of living today. And I don't think it's as easy and comfortable and relaxed compared to when I was younger. And so, yes, everybody has stress, but I just think it's a little more. And then I think the input coming into people is extreme. There's no time to just like relax, and just take in their world. I think there's just so much input from so many sources. And I think that, when I was young, we didn't go to the doctor. Now everybody goes to the doctor, especially young people are very, very, bring their kids to the doctor and everything is treated. And we're kind of over treating everything, whether it's ADD or acne, or they all have something, and so they get a medicine. So, and medications cause a myriad of problems. According to who you read, it's either the first or the third leading cause of death. And so no one.
It's such an important point. I was just having a conversation with someone, a family member who is really not, doesn't read and natural health, isn't particularly health conscious. And it's always, I'm so embedded in conversations with other health experts that sometimes I can be very dissociated from how most of the population thinks about these kinds of things. And I brought up exactly the point that you just did, iatrogenic harm, and the fact that pharmaceuticals are essentially the third leading cause of death, maybe the first, depending on, I've seen that too, that some people estimate it to be even higher, more like 450,000 or greater, instead of, I think the low end is more like 200 or 250,000 deaths per year in the US. And his response was interesting. It was like striking to hear this response. Well, how could drugs be harmful if they're supposed to be medicine that help people? And it was such a sort of basic, rudimentary question that it almost shocked me for a second before I answered him. And I said, well, you know how when you watch on TV, every time you see a drug commercial, at the end of it, they go, side effects may include da 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 da, and potentially this and this and this medical problem and that medical problem and death. Well, why do you think drugs always have those kinds of side effects? And it was a shock for him that he was realizing for the first time that drugs don't just have benefits, but they also carry risks of harm. Anyway, I thought I'd just insert that because it was very shocking almost to just hear how most people have been indoctrinated to think about this topic.
Right. Well, they present it as it's going to save your life. And if you look at
Exactly.
the commercials, they're always these happy, wonderful people. And I'm like, that's not at all like it is.
Yeah.
Okay. But they have you believe and mesmerized by this is going to, you're going to have your life back. And like I said, there are opportunities for using medications in the proper context. But you bring a good point about a perspective. And every head's another world, right? So in his world, that's his front row seat, right? And in your world, it's what you are exposed to because that's all you are doing is devouring the literature and health and talking to health experts.
Mhm.
So, but it's also an opportunity to cooperate and collaborate and say, well, let me explain my how I see it, and then give him the opportunity to explain his, because I think that's where it gets. We just get these volatile conversations
Sure.
instead of like, let's all look at this and
Yeah.
see, because our main goal and intention is how to make the other person better.
Agreed. So I've asked you, to start this conversation, I asked you what are some of the biggest misconceptions in the general public about cancer. I'm curious what you would perceive as some of the biggest misconceptions in two other groups of people. One is conventional allopathic medicine. What are some of the misconceptions in cancer? How do they perceive things? Or you could say, maybe you could answer it not necessarily in terms of their misconceptions, but maybe speak to how they perceive cancer, the nature of its causes, and how to address it. And talk about in natural health, holistic health circles, how many people perceive it there. And then tell me where you stand in relationship to those different views.
Okay, so that's a great question because I am a medical doctor, but I combine the best of conventional Western medicine. So that can be blood work, that can be scans, that can be biopsies, that can be many different things. And every patient, if they have a lump or bump or something that needs to be investigated, should, first of all, before they do anything, I always tell people, be precautionary with everything that you do, because we need to look at the good, bad, and the ugly, like you just said, the risk. Okay. So I think a patient will go to a doctor, and let's just use breast cancer since that's the number one cancer. And it will look suspicious on whatever imaging they're using. And they'll say, I need to do a biopsy. Well, when I recommend a patient to do a biopsy, because the gold standard is to do a biopsy so you know the pathology. Because is that breast cancer? What kind of cancer is it? It could be a neuroendocrine tumor or something else in the breast, as opposed to an ER positive, PR positive breast cancer, right? And so I usually prepare the patient before, during, and after the biopsy. All right. And so that's one thing. Then once you get it, I always recommend to patients, since I'm not an oncologist, go and speak to a surgeon and oncologist and listen to everything they say. Probably do a couple of them. And then ask them, why do you think this happened? Now, most doctors will say it's bad luck, or you have a genetic, depending on their family history. And then no one will really tell them the causes of the cancer, actually. And so when I see a patient, I will go through a detailed since in utero to where they are now and what's happened to them their whole life. Okay. I go over an entire lifestyle. And then if the patient, and I order very comprehensive blood work. Typically, doctors order a chemistry panel and a CBC and maybe a tumor marker. But what about their C-reactive protein? What about their hemoglobin A1C? What about their vitamin D levels? What about their hormone levels? What about, your immune system? All the things that need to be checked if a person has a serious diagnosis as cancer. And so conventional will just go attack the cancer, like remove it, and then they will decide if the patient needs chemotherapy. And unfortunately, sometimes you may need to incorporate chemotherapy, especially if cancer's stage 3 or 4 and you've got to shrink it. Now, in my clinic, I do insulin potentiation chemotherapy, because cancer cells have insulin-like growth factors, so that we give the patient insulin, bring the patient down to the therapeutic moment, and then give the chemotherapy, trying to preserve the other cells. So that's only given at 10% dose, sometimes 20, but a much lower dose, but a targeted approach. In the conventional world, they will use the typical dose-dense chemotherapy. But if you give chemotherapy, what are you doing to protect the patient? There should always be protection in everything you do. Even if you were to give a medication for any chronic disease, what's the protective nature of giving that medication, right? What are you, like if you give antibiotics, what are the things you should be doing to correct that person once they've taken the antibiotic? And then I'm looking at oxygenation. I draw an immune panel on everyone. I'm looking at environmental pollutants. I'm looking at their gut. I do a GI map. I do hormone testing. So in conventional oncology, it's surgery, chemotherapy, or radiation or immunotherapy, some combination depending on the diagnosis and extent of disease. So some patients may need those treatments, especially if it's very extensive, but I will, do intravenous vitamin C and curcumin, and to alkalinize them, I'll be doing IV sodium bicarb. I do ozone and ultraviolet blood irradiation with this ozone, which is a treatment been around for 100 years. So I will add all these other supportive therapies to maintain the integrity of the patient, at the same time that if a patient needs surgery, if they need chemo, and another thing I do is repurpose drugs. There's over 400 drugs that have, blocking cancer in different ways, and hyperbaric oxygen. So correcting their nutritional deficiencies, all these. And then I have them do things at home, all right? Whether it's a detox bath. I like to do emotional work on every single patient, just because I think that is just another piece of the puzzle to address people who've had, unresolved emotional conflicts or extreme, drama and stress in their life. So that's the difference is, conventional pathway is drug, surgery, or both, and maybe fancy medications. But what are you doing to keep the patient integrity great and wonderful while you do those injurious immunosuppressive processes?
There are on the other sort of the flip side of this, we have a lot of people over many decades who are in the realm of natural cancer treatments and natural cures and things of this nature. And I want to be a little sort of cautious in how I talk about this, to not conflate things that may be largely legitimate and things that are nonsense. But just for the ease of asking you this question, in this broad umbrella, under this broad umbrella of, let's say, natural cancer treatments and natural cures, we have things like the Gerson therapy, which actually my grandma went to in a clinic in the Bahamas decades ago when she was diagnosed with cancer, and actually had a successful cancer remission from it. And this was at a time when, there wasn't much of a culture around alternative cancer approaches. It was considered very radical and crazy to do something like that. And then there's lots of, I've seen over many years, there's lots of other claims of all kinds of stuff, that cancer isn't really what we think it is, that it's a fungus, or that it's a virus, or that it's this or that, and if you use this antifungal treatment or put baking soda, inject baking soda into the tumor, or I've seen all kinds of stuff like that. There's also this pervasive idea that there are cures that have been actively suppressed by the pharmaceutical industry. And maybe that's something you want to separate out from your answer here and address separately. But I'm curious, what do you consider to be some of the biggest misconceptions out there within the natural cancer treatment approach?
Right. Well, I'm bit familiar with the Gerson protocol, and I've had many patients do that. And I will partner with the patient if they want to do. They'll say, "No, Dr. Keneally, I've read everything. I want to just do the Gerson protocol. And will you follow me?" And I say, "Absolutely." I have patients come in, "Dr. Keneally, I have a lump in my breast. I know it's under my arm, but I am not doing chemotherapy, and I will partner with them." Now, obviously, I make each individual decision based upon the patient, because if like they're really young, cancer tends to be more aggressive. So I will watch them monthly, and then the other patients, they're older patients, I can watch like every couple of months. So I'm very familiar, and I always say, you don't know until you do it. And you mentioned about injection of sodium bicarb. I met Dr. Simoncini, who has the website Cancer Fungus, and they all thought he was, a renegade in doing it, talking about doing IV baking soda and injecting baking soda into tumors. Okay, I personally have not done that. I do IV baking soda all the time, every day here, because that's a very, very beneficial way it's antifungal, plus it creates an alkaline environment. So I just think that in each individual case, I will say, I'm more than happy for you to do any of those, and you don't know, because there's so many factors at play. And the Gerson protocol has lots of really good things, because the people who have continued the Gerson protocol, which was Dr. Kelly, who wrote the book One Answer to Cancer. And then if you look at the work of Dr. Gonzalez, he was also, he's dead now, but his work continues on. But there's lots of pearls to all of that, like the pancreatic enzymes, the coffee enema, and I utilize all those. Okay. And if a patient, I believe that everyone has a sovereign decision that they need to make in their care, because I have patients all the time. I am not going to do that, Dr. Kenealy, and I honor their wishes. And I tell people, you don't know until you've tried it. Now, if it's something that I've already done with a patient 20, 30, 50, 100 times, and I realize it doesn't work, then I will say, I haven't found that to work in a lot of patients, but I'm more than willing to partner with you. And I think we doctors, their biggest mistake, I think, is not looking at everything. They're so in medical school and in training, and when you get training in the hospital, you are just taught that one thing to do with every patient. No one's taught about, how do you eat? How are you thinking? What are you exposed to? And 100 years ago, all doctors had is natural treatments. So that's all they had, whether it was essential oils or baths, or making special things in their office. I mean, that's all they had 100 years ago. So, and coffee enemas have been around for 100 years. So I think there's a lot to the natural things, but you have to combine them both and not endanger the patient.
Mm-hmm.
And make sure, so they know, because they need to know all the risks that they're taking.
There's a subtle aspect to what you're communicating that I just want to point out to listeners. I think that we all sort of grow up with this perception that, if I get older and I'm unlucky enough to get diagnosed with a particular disease, like a particular type of cancer or something, that that I would go to a doctor and there would be sort of this scientific consensus of here's exactly, what type of cancer you have, what stage of cancer you have, and here is the exact treatment that you should do, and all doctors agree this is exactly what you should do, and this is the exact correct approach for this particular problem. And I think that when people actually get into that situation, they discover quite the opposite. And this is true of a large number of diseases, not only cancer, that you experience that there isn't a consensus and there isn't a perfect treatment for it. And there are some treatments that, maybe some research shows are beneficial in some people, and other research maybe puts that into question. And some experts are a fan of a particular treatment. Some physicians are not a fan of that particular treatment and recommend a different approach. And it is this sort of vast landscape of complexity and differing and sometimes contradictory views and opinions and approaches that can be almost maddening for the patient. And the way you're talking about it is as a physician, you're saying, well, I also have on top of everything that I just said, you're saying I have a relationship with the patient where I also respect their views and their wishes and what they think is right, and what is their approach and what they want to do or not do, and say I'm willing to partner with you, which ultimately I think paints a picture of this whole process almost as less of a rock solid science and more of an art.
Right, exactly. And because, what I find a lot of times is what is the relationship and partnership that you have with each person. And a lot of times people, geez, I think the care of medicine is gone. And I would say one of the number one complaints I hear from patients is the doctor isn't interested in anything else that I have to say or talk about. These are the rules because the doctors have to follow NCCN guidelines. If they're an oncologist, they follow the guidelines in the book. And this is in this group of patients, this is the treatment and this is the outcome. And if you add this extra layer, you might get an extra year, you might, depending on the situation, right? But they have to follow those guidelines as an oncologist.
Otherwise, their license is at risk?
Their license is at risk, and the corporation they work for will not be happy if they don't follow those guidelines.
Mm-hmm.
All right. So because I'm not an oncologist, I can look at every single thing that's possible for the patient, as long as I have properly educate them and I have told them conventional as well as other treatments. And I give patients, here are your options. Here's a drug you can take for your blood pressure, or I can give you natural herbs to bring down your blood pressure, or arginine, or something, whatever concoction I decide. Now, if a patient comes in with high blood pressure and it's a blood pressure that's very high, I will institute medications, but then I'll say, okay, why, where, when, and how did you have this problem? And I will start, maybe they're not sleeping, maybe their weight is too high, maybe they have lots of other things going on, too much stress in their life. But we don't want to ever endanger a patient. And so the patient needs to know that we're going to try this and make sure and ensure that, your blood pressure goes down, but also, why do you have this blood pressure to begin with? So it's very important to inform the patient of all the, the best thing is informed consent about everything, whatever you're going to give the patient. But drugs are the only tool that a doctor has, and or surgery, to fix a patient. And most of, all diseases usually have many underlying factors that are contributing to their disease process.
Mm-hmm. I have a couple questions in relationship to that, but one thing I think might be interesting to address is there might be I'm imagining sort of two groups of people listening to this. One who are maybe hardcore naturalistic, people who only approach cancer through, natural compounds. And they might say, well, you sometimes use chemotherapy, how could you? And then on the other side of this, you have people in conventional medicine who, as you just outlined, have to adhere to the what's the body, the
The NCCN guidelines.
NCCN guidelines, who are maybe listening to you and saying, well, who do you think you are? To you think you know better than all of the established consensus among oncologists as far as how we approach things. How dare you think for yourself and sort of approach things or think that you could know better than all of us. I'm just curious what you would say to someone who maybe is approaching you with those kinds of criticisms.
Right. Well, first of all, we should all be cooperating, collaborating for the healing of the patient. Okay. And so if Dr. So-and-so at a major cancer center down the street has all the answers, okay, great. I'll listen to it. But if the extreme natural person, which I would consider I'm a pretty extreme natural person, but at the same time, if a patient comes in here and we're facing very serious, dire consequences of not doing something, then, we all have to work together for the healing of the patient, period. Mm-hmm. And if it takes all three of us to get the patient healed, that's what we should do. Okay. And I think that is a problem because I don't know of anyone who has all the answers. Okay. And as far as I'm concerned, every patient is N of one. They're their own clinical trial. And I don't think we're ever going to achieve anything being against another person's opinion on how to get a patient healed. Mm-hmm. Okay. So, because in fact, one of our doctors had a situation a couple of weeks ago where a oncologist called and said, what are you doing? Are you an oncologist? And the doctor said, no. I'm actually started in pathology and did internal medicine. And, now I'm doing what I'm doing now. And so she tried to, help the doctor understand what they were doing and how we can work together, because that's really what we need to be doing. Because it's not about the doctor. It's about how we're going to heal the patient. Mm-hmm. And I work with oncologists all the time. And I tell the patients, I always tell every patient, go and see what the doctor has to say and look at all of your options. And then we'll come back and discuss, okay, if the doctor said X, well, let me explain that further to you so you understand the ramification of that plan and then how we're going to protect you during whatever we have to decide that. Because like some of my patients, they need dose dense chemo. They need the full thing if they've got pancreatic cancer and the low dose chemo is not working. And so I tell the patient, and then I tell the patient, this is what we're going to do to mitigate and enhance your vitality and integrity of your body right now, and how we're going to enhance the healing of all the damage of the chemotherapy or the immunotherapy, whatever drug that we're using.
What do you think, and this might be a difficult question to answer because I know there's lots of nuances to it. It's sort of a mixed bag of yeses and nos, but what would you say to the question of how would you conceptualize the efficacy of chemotherapy more broadly in terms of treating cancer? So I remember years ago, and it has been years since I read this, so maybe things have changed, but I remember reading papers on the efficacy of chemotherapy that were basically saying that for the vast majority of types of cancers, most of the chemotherapy options are of minimal effectiveness. What's your take on that, sort of speaking in with broad brushstrokes?
Yeah,
that's possible, true. Or maybe that's a bad idea. I don't know.
Yeah. No, that is true. It has very low efficacy, and patients today, a lot of patients who do their research know that. And that's why I say we can't put all of our healing in just the chemotherapy pathway. You must do all these other things if you want to enhance your survivability.
And what would you say if someone says, well, what if I believe chemotherapy is fundamentally bad for me? You know, rather than a contributing factor to my healing, what if it's actually at odds with me doing some of these other therapies?
Then I will tell them, if you don't think chemotherapy is right for you, then we will try all these other modalities to see if we can heal you without chemotherapy. Because there's some people, you know, there's the placebo and nocebo. So if you don't think it's going to work, it's not going to work.
Right. And that placebo and nocebo dynamic adds a whole other dimension of complexity to this, because if you, let's just imagine you had a treatment that is actually helpful, but somebody believes it's bad, or somebody, you know, then what's going to be the end effect of that? Or vice versa, if you have a treatment that is maybe no better than placebo, but somebody thinks it's extraordinary, maybe it can actually lead to a very beneficial effect. But I think the misalignment there is much more important. If the doctor wants to administer something, but the patient fundamentally has a belief that it's actually harmful to them, now you're, you know, who knows what the effect of that thing is going to result in. Let me ask you this. So how central do you think chemotherapy is in healing people with cancer? Are you able to have remissions of cancer without, you know, how common is it to get remission of cancer without using chemotherapy and using some of these other modalities?
Well, right. If someone has just a simple lump in their breast, they can do surgery. Over 70% of breast cancer patients are not going to benefit from chemotherapy, because there's a test you can do called the Oncotype DX, and it will tell you if chemotherapy is going to be benefit for you or not. And over 70% of cases, it's not.
And is that also true of a number of other types of cancers that are fairly common cancers, that they are non-responsive to chemotherapy?
Right, because there's something called chemoresistance and chemosensitivity. And, you know, you got a 50-50 chance whether it's going to work or not. That's why you can't just rely on just chemotherapy, because the chemoresistance and also the circulating stem cells and tumor cells are get very angry and upset under chemotherapy. And they don't, typically the doctors aren't checking that even. So, and then you're making the terrain significantly more unhealthy, right, when you give chemotherapy. But like if you take a pancreatic cancer patient, for example, which is a very aggressive 90% fatality in, you know, less than a year, all right? So, you know, that you probably are going to need chemotherapy, either low dose or conventional chemotherapy, all right? But, you know, no one recommends chemotherapy unless there's really an absolute need for it. So, for example, if you have stage 4 cancer and the cancer's traveled to new organs other than the breast, then of course you're going to have to shrink it, and chemotherapy is necessary. If a patient comes in and says, you know, Dr. Connealy, I just do not want to do chemo. I know that I have stage 4 cancer, but I just want to take a repurposed drug and naturals and IV vitamin C and sodium bicarb. I'm like, okay, you know, and we'll do the scans to see if you're getting better.
And then if they are, awesome. And does that sometimes happen? That somebody is getting better? Okay.
Yes. I mean, chemotherapy doesn't have 100% slam dunk. Okay. Like if you do chemosensitivity testing, right, you'll see there's no 100%. It's 60, 50, 70, 80, but nothing over 80%.
You're talking about the efficacy in causing remission, or just
of killing the cancer. So like if you put it, you know, if you send your blood and get chemosensitivity testing from different labs, there's no 100% kill rate.
That's the predicted kill rate.
Right. You know, there's no 100%. So, you know, there's nothing that's 100% kill rate. So. So you have to, that's why I always tell people, we just rely on chemotherapy, right? I mean, we have to incorporate all the different, drains to the system, you know?
Um, I know this is another question that's hard to answer, but how would you sort of paint the picture of the number of people who, once they get a cancer diagnosis of any type, go on to die relatively rapidly versus those who are the percentage that are able to um, go into remission or keep it at bay enough that they still live a normal lifespan?
Well, I think that's really dependent upon what stage they are. Like stage 1 and 2 is much easier to reduce, you know, um, a reoccurrence. And we don't have really good testing in the conventional system to prevent a reoccurrence. We don't have, like, typically doctors will order scans and minimal blood work. So they're just waiting. They're just waiting. They just tell the patient, I'll wait till you have a symptom before I do anything. So we don't have any safeguards in the system to prevent reoccurrence. Whereas here, that's all we're trying to do is help to prevent a reoccurrence. So stage 1 and 2, I think, is easy, but we have a lot of patients who are stage 3 and 4, and they do everything and they're able, to prevent reoccurrence and stay
To
cancer free for,
to get remission.
yeah, to get remission and stay there and, keep check because they get an annual checkup with us once they're really, really healed and they are in remission.
Because
So
I think I
that's
think a
somebody, yeah,
I think a lot of people have been trained to see a cancer diagnosis almost as a death sentence. Like, if you can't cut it out, cut the tumor out surgically, it's almost like, people think it's going to kill them. What would you say to somebody who has that impression, sort of as maybe the percentage likelihood of being able to treat it in a way that you can go into remission?
right. Well, cancer I think most people perceive it as a death sentence, even if it's really small. So I explain to them how this is completely, you're going to fix this and keep, your whole mission in life is how never to get any cancer again.
Mhm.
And that's my goal with the patients, and the patients are, that's what their goal is too, once they know that that's an option. A lot of them just think that cancer is a death sentence, it's going to kill them, and then they're very fearful all the time. Every little thing that they feel, it's coming back, it's coming back. And
Which
so
itself is a big problem.
it's a big problem, right? So in our cases, we're able to really teach and educate the patient. And then the testing that I do, we do circulating tumor cell tests. We do bioenergetic testing also because I can't find everything on a scan and blood work. So I do other kind of testing to look what else is going on in the terrain. And I always do emotional work on every patient also. And so, you become what you think about most of the time. So if people, are living in unreasonable stress all the time, I mean, it's going to be very difficult to get better, right? So I think, if they don't address all the facets that got them into the situation, then it's going to be very difficult to keep them out of the situation. But it's our system doesn't educate and empower patients on how to get healed and stay healed. It's like we focus on sickness and illness and disease,
Yeah.
not about optimizing someone and de-diagnosing their problems. That's what we should do as doctors. We should be de-diagnosing. If you have high sugar, okay, you can have a body that doesn't have high sugar. If you have inflammation, you can fix these things. We're living in 2024. Please, this is, ridiculous that
Yeah.
we can. And an early stage cancer is very easy, really easy to fix and keep people in remission and teach them and educate them on how they're going to keep themselves in remission.
What do you think of the metabolic theory of cancer and keto diets in relation? What role does that have to play in this picture?
Right. Well, keto's been around for 80, 90 years, 1930, I think, when it was first used for epilepsy. And I think it can play a role in cancer, especially when patients are pre-diabetic and diabetic. So if you check their hemoglobin A1C and it's elevated, we know that that is functionally weakening the cell. So a ketogenic eating program might be very good, especially like for brain cancer and for pancreatic cancer, because when pancreatic cancer patients, you don't want their pancreas overworking. So you definitely want to prescribe them a ketogenic eating. And also for brain cancer, if you study the work of Seafried, the metabolic approach to cancer. So I do, and I talk about that in my book. But is it a one size fits all? No, but it can be very, very helpful for patients who with different cancers and looking at their blood, looking at their fasting insulin, fasting sugar, and their hemoglobin A1C. So I think it's helpful.
I have like 20 other questions I want to ask you, but we won't have time for them. So we may have to do a part two here.
Okay.
I have a couple more things that I think are important. One is screening. So when it comes to screening, we have lots and lots of public messaging from the medical institution that we have to get regular screenings. It's really important to do these diagnostic checks. We hear these horror stories of people who wait too long to get diagnosed. Now they get stage 4 cancer and their life ends. And, if it was caught early, they could have prevented it. And so we all kind of assume that regular screening and testing is really critical to preventing bad outcomes. I was relatively shocked to learn recently, as I dug into that literature, that the evidence to support regular screening is actually pretty weak and pretty controversial, even for just like yearly physical exam checkups. But a lot of different kinds of medical screenings actually have very weak data to support them. Having said that, it still is the case that there are those instances of people who were caught late when they could have been caught early and leading to very tragic outcomes. I'm curious what your overall take on that subject is.
Right. I think screenings are not very beneficial at all. And it's obvious because the cancer rates are going higher. Now, and there is no screening for young people, okay? The first screening is a colonoscopy at 45 for men and women. For females, it's a pap smear, and they don't get breast screenings till 40. And a lot of the new breast cancer patients are younger. And then PSA screening is not recommended, even though it may be beneficial by testing it and looking for the change in the level as opposed to the quantitative number. So if a patient's always been 1, PSA of 1, and they jump to 2, we probably know there's a problem. But for males, it's 45, and PSA screening, maybe yes, maybe no. And for females, it's pap smears and breast screening not until 40, and mammograms still are the standard of care. There's new imaging called QT, quantitative transmission, which is no radiation, no dyes or anything, and 40 times the accuracy of an MRI. So the screening is not that great. You're right. So that's not how I screen for patients, because prevention is priceless for me.
I think we should just wrap up part 1 on this because I
Okay.
have way too many other questions. It's going to for sure be another 40 or 60 minutes of conversation. And I think it's important that we go into some of these questions that I've outlined. So part 2 is in the works. And for people listening to this, let me know in the YouTube comments or email me, ari@theenergyblueprint.com, with any good questions, things that I haven't asked here that you'd like me to ask Dr. Connealy in part 2. Dr. Connealy, this has been a fascinating discussion. Thank you for indulging me in all of my long list of diverse questions. I have many more.
Okay.
I want to seed one topic that I'm very excited to get into with you for the next episode, and that is, I've seen you talk about this and share some of the research that supports this, and this is fascinating, that cancer cells can revert back to normal cells. And I think just that knowledge is very empowering, and especially looking at, I saw some of the research that you shared related to this and some of the factors that influence it. And I was unaware of that research before I saw you share it. And I felt it very insightful and very empowering. I mean, even just seeing that really changed my perception of what drives cancer and how we can avoid it. So I'm excited to get into that with you. I think it's a really important topic, and I have a bunch more things on my list here. But we'll leave part one at this. Again, to everybody listening, let me know what questions you'd like me to ask Dr. Connealy in part two. And Dr. Connealy, thank you so much for sharing your wisdom with my audience. I really appreciate it. And let people know where they can follow you or get in touch with you to work with you.
Right. They can follow me on Connealy MD, the Instagram, that's my handle. And they can look up Center for New Medicine, Cancer Center for Healing. And we have a regular cancer conversation every 2 weeks. That's on Zoom, that's recorded, that you can find on YouTube.
Beautiful. Thank you so much. I look forward to part two.
All right. Thank you.